Okay, so welcome everyone to I think it's the second EU webinar for this year. And this year we're focusing on supervision and training. And I'm really excited to welcome Erkki Heinonen to describe aims, methods, and some of the findings of the SPRISTAD longitudinal study. And just a few words about you, that Erkki Heinonen works as a professor at the University of Oslo, in addition to which he holds a private practice. He also leads the Helsinki Psychotherapy Study, a large randomized study of short and long-term psychotherapies. His research interests include what works from whom and why in psychotherapy, and whether nature or nurture produces effective psychotherapists. He participates in several international collaborations and therapist training, currently chairs the SPR Interest Section on the training and development of therapists. So thank you, Erkki, and we'll start. If anyone has questions or comments, please put them in the chat, and if it's kind of urgent or some misunderstanding, I'll say it out loud. Otherwise, we'll keep it towards the end, okay? And we'll run for about an hour for everything together. So please go ahead.
All right. Thanks very much, Oria, for the invitation. And very nice to be here. And it's big and to some degree an undeserved honor to present the SPRISTAD longitudinal study, since there's many people who have been involved in the study, and on behalf of whom I'm really presenting this. And I thought of opening with a slide of the portraits of just everybody who was involved in those initial meetings when the SPRISTAD longitudinal study was first discussed in some SPR meetings. But there were a huge number of people present. I don't think there's any photographs, and I figured I'd just forget somebody and end up on somebody's blacklist. So I thought that, suffice it to say that many of the big names of SPR were in those initial discussions, and there was a shared sense that this is a really important topic to investigate. And so my aims are, and can you see my slides? And they're changing? Yeah, excellent. So my aim is to give a brief history of the SPRISTAD longitudinal study, what were the aims behind it, the design and methods developed to achieve those aims, and some of the findings to date, and then mention some future perspectives. And by the way, if you look at the upper left-hand corner there of the map, you can see there's still a couple of continents we don't have in the SPRISTAD. So especially if you're from Africa or Australia and you feel like you'd want to participate in the study, you can shoot Ulrike Wilutsky or Jan Pirke an email, who are our study coordinators. There's still data collection ongoing, and also you don't need to be from Africa or Australia. There's also some countries, including in Europe, where data collection has recently started or is starting. And I'll show these emails also at the end of the presentation. But so to kind of situate the birth of SPRISTAD in its zeitgeist in the early 2010s, what happened in the previous episode, so to speak, this was when the research interest on psychotherapists was really starting to rise. And I have some screenshots here of some papers, which is not to say that these were the definitive studies settling this or that point, but just some examples of the situation, which was that there'd been several decades of randomized trials of comparing different psychotherapies, not really showing substantial differences in the effectiveness of various therapies for common mental disorders. And also, we'd seen that a good working alliance did really have a consistent effect on outcome. Also, it had become recognized that the therapist had become a kind of neglected variable. And then the great psychotherapy debate, of course, having been one of the influential publications putting this together and including directing attention towards the fact that therapists differ in their effectiveness also. So it became of much interest. What are the therapist characteristics actually underlying those differences in patient outcomes, which also happened to be my PhD topic at the time. And then the other logically following question was, of course, how do these beneficial therapist characteristics develop? And so there was a critical mass of people building up in SPR, interested in looking at how therapists develop. And I checked this with a couple of people, and so I hope it's not just my memory, but it was in SPR Bern and in Virginia Beach where these discussions really kind of began. And I'd had the fortune of having started working with David Orlinsky a year before in Chicago, and David was really the primus motor in SPRISTAD as an interest section, and also in the SPRISTAD longitudinal study. So I had the fortune of being involved in both from the graduate student stage. And I remember this brought quite a few people together, which was, of course, the point of these interest sections, where the sort of different geographical factions of SPR can sometimes sort of keep people apart in a sense, or have that unwanted, unintentional effect. The interest sections are really to bring people together. And of course, if you can do it in places like Bern and Virginia Beach, it's all the nicer. At the same time, also, what happened was the latest edition of Handbook of Psychotherapy and Behavior Change came out, where Sarah Knox and Clara Hill reviewed the current status of therapist training literature. And there was a recognition that extant research had a bunch of common limitations, often small samples, cross-sectional designs, and being conducted in a single site or locale. And the idea was that maybe some of these might be, these limitations might be circumvented with international cooperation. And there were both quantitative and qualitative large-scale cross-sectional studies, which in recent history, which also served as precedents and informed the SPRISTAD study quite influentially. The SPR Collaborative Research Network, or CRN study, being one, with David Orlinsky again being the primus motor behind that one, which had collected data from close to 5,000 therapists from over 20 countries by the at the time the 2005 book was published, and now the database being already over double that amount, and representing therapists from their 20s to their 90s, so really all career stages. And the development of Psychotherapist Common Core Questionnaire, the DPCCQ, which was the measure developed for that study, and the data source in it, then also provided a lot of the items for the SPRISTAD questionnaires, which I will go into shortly. And the other study to mention was the Helge Ronestad and Tom Skovhold's so-called Minnesota study, which was geographically more circumscribed, but was nevertheless quite large for a qualitative study, having 160 interviews with 100 therapists of all career stages, and interviewing them about their development. And both these studies are crucially really focusing not just on professional experiences and qualities of the therapist, but also their personal life, the person of the therapist. So the aims of the SPRISTAD longitudinal study then came quite simply to be tracking progressive changes over time in therapist trainees and identifying factors that help or hinder trainee development, whether those factors are professional or personal, and to do so using quantitative and qualitative data gathered from a large number of psychotherapy trainees of varied types and in a wide range of training programs. So this begs the question of what is actually development. And this was conceptualized as firstly changes in what the therapist does. You might call this role performance aspect of the therapist profession if you're a sociologist. And secondly, changes in who the therapist is or how the therapist experiences him or her or themselves to be, which might be called the role identity aspect of a professional. And I'll go further into what both these domains comprise. But just to say before that, it was recognized that both these aspects could be plausibly impacted by a bunch of stuff like personal therapy, close personal relationships in private life, major life events, all of which can interact with the effects of training and supervision. And so the next mission then was to develop the methods for actually assessing these domains. And as the plan was to carry out this longitudinal study in numerous countries and with varying resources available, in those places, it was clear that self-report was the most feasible way to go rather than extensive interviews. And so 5 questionnaires were developed, of which the first 3 have been implemented throughout the study, and the last 2 focusing on trainees' particular cases from both trainee and supervisor viewpoint have been optional. And I'll go now to what these questionnaires actually assessed, and I'll say, or I'll note kind of the main themes, but I'm not what I say doesn't cover everything that the questionnaires comprise, which are really very large. So first, the trainee background information form. This drew heavily on the DPCCQ, and in there the items that were obviously we drew on the items that were thought to reflect mainly stable attributes for the background of the therapists. So on the professional side, these were questions like background, profession, and degrees, past other earlier careers, if people had them, past clinical experience, the amount of the clinical experience and supervision, and also the personal therapy and reasons for it, whether it was for personal growth or training purposes or own problems and so forth, and including to what degree had people felt that was helpful for them. And then on the personal side or the like private life, there was everything in the kitchen sink, as I guess the expression goes. So historical things, life historical things like size of the family, whether you had brothers or sisters, whether parents were divorced or died, and at what age that had occurred, whether you'd be considered a member of some social or cultural or ethnic minority, whether there was a religious upbringing of some denomination, what were the economic surroundings growing up, and the psychological surroundings growing up, experiences of care and experiences of trauma. And already from the CRN study, we of course know that a substantial proportion of therapists, almost half, not having experienced at least some significant emotional abuse and trauma in their lives. And we were expecting therapists not maybe just throw the word around. So these were the things we asked about the life history. Then we also asked about current life, things like life satisfaction, life stress, economic situation, marital status, parental status, experiences in close relationships, attachment patterns, basically, and self-identity, like how do you experience yourself as? And this was also understood or conceptualized in terms of like how you feel you are with people. Then, so that was for knowing what kinds of people come in and start in training programs. Then the other part, obviously, we wanted to know about was about the training programs. And here we had an instrument that was developed by Bernhard Strauss and colleagues for surveying German training programs. And this was then adapted to be fitting for an international context. And sought information like which theoretical orientations are taught, treating which diagnoses, which modes of treatment, individuals, couples, and ages, and whether minority issues were specifically considered. And then we asked about structural stuff like how the candidates are evaluated, how many get in, how long does the program last, and so on, and whether it's part-time or full-time. And then to the actual training contents. First of all, the academic elements, such as basic psychological theories and research, developmental, cognitive, social, and so forth, main psychotherapeutic theories of leading thinkers, psychopathology, intervention planning, research findings, multicultural ethnic issues, and things like this. And then models for practice, where you actually see something of what you're supposed to do, such as provided by the program trainers or via technology, like watching videos. And I should also mention that later on, we asked the trainees, how many hours per month did you spend on each of these elements? So we also got a sense of the actual amount. And then after seeing models of what to do, the actual doing or practicing. So things like basic helping intervention skills and common factor relationship skills and role playing with program other trainees or with simulated patients or real therapy patients, and then if there was some kind of sensitivity training group experience in there. And then we also had an option for other specify for these different elements here, and also for the other sections if there was something else. So that was the experiential part, the doing part, and then the next part was on how do the trainees actually get what forms of feedback were used for shaping trainee development and facilitating change. So feedback by trainer or supervisor or other trainees, or formal supervision, or individual personal self-reflection tasks, or balanced groups, or personal therapy. And then finally, what kinds of methods for assessing and diagnosing and conceptualizing cases were taught. So like diagnostic systems, interviews, clinical case interviews, diagnostic interviews, psychological tests and measures, and other sort of family relationship assessment methods, behavioral observation, behavior analysis, diagnostic classifications, and then other specified. And then finally, the formal requirements, like how many treated cases do you need to have in this program, and how many supervision hours do you need to have, and whether there's a thesis involved. So that was the training program contents, and then after these two things, which kind of like set up the baseline at the start, knowing what kinds of people come into training programs and what they are taught, then we want to see whether and how they actually change. That really being the main aim in this study. And so here again, the items were largely drawn from the DPCCQ, and this time on the on the domains and the experiences we presume to change in the course of training. So we asked about firstly practice characteristics. Well, these wouldn't necessarily change, but these would be important for understanding the context. So we'd ask about the amount and type of clients trainees saw, whether they work in or outpatient, public or private, and so on, work setting, how much kind of support, how much control over their own work they have in their work setting, which also typically is can be meaningful for work satisfaction and many things, and things like this. And then I'll just say here kind of briefly, but I'll go into this in more detail just shortly. But so the things we were most interested in were how did therapists' experiences of their various skills in therapy, as well as the difficulties they encountered, change during the course of training. And this is really the role performance aspect of therapy, to what the therapist does. And then secondly, we were interested in how the change in how therapists experience their relational way of being in therapy and their feelings in session, which relates more to the developing role identity as therapists. And then we assessed various aspects that could impact those experiences both positively and negatively, like experiences with patients, various aspects of the training, courses and seminars and workshops and supervision, informal case discussions with other trainees, readings, personal therapy, model-based learning, the institutional conditions already mentioned, and then just experiences outside of the whole therapy thing. So these were the things we wanted to ask and their impact on these experiences. And then we asked also directly how trainees experienced their change, whether positive or negative to that date. So such as how much do you feel you've overcome past limitations as a therapist, and how much you feel you realized your full potential as a therapist. And we asked also about personal life, like how satisfying and stressful is your private life. And I don't know if you've seen this meme of Ben Affleck in between takes on some movie set, probably being some action hero here, but I kept, imagine it can capture some feeling that therapists may sometimes also face um, between clients and uh, and these sorts of things. And then finally, we inquired how experiences in the trainee group influenced trainees in both positive and negative. To what degree did they feel they're part of a cohort, a sense of support and camaraderie, and or a sense of competition or divisiveness. So, so those were the measures, and then the design was that and the procedure that our training programs and trainees were recruited through various means during SPR conferences, obviously, and workshops, and other networks and mailing lists, and so on, which led then in time to opportunity samples that actually started to have some size. And training programs were eligible to participate if they lasted at least a year. So we were able to actually study longitudinal change. And then the training programs would inform the trainees, which if they wanted to participate in the study, they could then provide their informed consent, after which the questionnaires that I described were sent to the trainees from the University of Witten-Herdecke by Professor Ulrike Wilutzki and Jan Pirke. Starting out with the trainee background information form, and then with the first trainee current practice report when they started treating patients. And then after 6 months and 12 months and 24 months was the basic plan. Of course, the longer a study goes on, the more you have dropout, and especially with the sort of long questionnaires that we have, it was unavoidable. So while we had a 1,400 plus trainees filling the initial survey about their background, considerably under a half responded to the first report on their current practice experiences when they started treating patients, and that dropped again with each successive administration quite significantly, although not as much proportionally. But nevertheless, it's left a sufficient sample for us to detect some changes in trainees, and which I'll go into shortly. So so yeah. On that note, actually, I'll move on to the findings, or the findings to date, I should say, because and I'll mention also some works in progress. And I'll go through this from the kind of the baseline in our study design, and finishing then with the longitudinal aspects. So, and actually, I mean, before that, something I want to mention, which is perhaps obvious, but it's that we have opportunity samples. So in other words, data from training programs and trainees who responded to us. And there's not really a base population to which we can generalize from our findings. But at the same time, we'd say this is really kind of unavoidably the case also when we study therapists or therapist trainees in an international context, because there's not really a universally accepted definition of what a therapist is. And these definitions differ very widely between countries. So what we can really do at best is to just note and observe whether we observe some general patterns, and further samples in any particular nation can then align with these patterns or not. But so having said that, and starting with the training programs in our data spanning 4 continents, and about 20 countries at least, we saw that almost 9 out of 10 therapist training programs required at least a post-secondary degree, like a college degree, or a postgraduate, like a master's degree for applying, and a bit more than 7 out of 10 required some occupational background too, like in the mental health field. How were the applicants evaluated then more closely? 90% of the programs had interviews with candidates, which was overwhelmingly the most used method. And the qualities that looked at were most often were personal qualities, like empathic ability, capacity for self-reflection, mental stability, and as well as intellectual qualities, theoretical interests in therapy, psychological mindedness. And so if we think about the implications of this, it's of course clear from this that training programs do put value in evaluating candidates' personal and intellectual qualities. And so from a research point of view, it then also underlines the value of, for us, identifying the characteristics of therapists that make a difference for treatment outcomes, which we still know unfortunately little about, really. And also, secondly, it underlies the value of being able to distinguish via research, hopefully, what are the characteristics that can be modified through training versus those that are perhaps more long-standing or shaped by really long-term development and could be helpful as selection criteria then. Just to mention some works in progress in this area, we're looking at how the different aspects of training programs and more exactly the amount of time that trainees reported spending in the different aspects of training, how these are how these kind of clustered together. First of all, we saw there were different factors emerging. I'm not going to go into them at the moment, but I'll just say the aim is to kind of look how sort of the time spent in these different aspects of training is then correlated with trainees' experience of positive and negative development, feeling more effective as a therapist or feeling more stressed out as a therapist, and also the theoretical approaches of the training programs. So like how much supervision there's and how much case-based learning and so on and so forth. So the terms named there at the bottom, healing involvement and stressful involvement, I'll say a few more words about them too very soon. So moving on to the people who are then selected to be trained in these programs. Who are they? How are they doing in their lives? I'm not going to present data on the background, profession, and demographics. We can't generalize really, as said, on those in any case, but I'll note a few interesting patterns and associations, and like to just note this old idea that people who train to become therapists, they must have a lot of problems themselves. Well, whether that's the case or not, we saw that a little over 50% of the trainees felt that their current life satisfaction was great or very great, while their life stress was moderate or less. And so we call these people feeling quite a bit of life satisfaction and not too much stress, fortunate or happy. And they were over half of our sample. And of course, not everybody was as fortunate or happy, but perhaps worryingly, especially, there were about 1 in 7 trainees who were experiencing great or very great stress and moderate or less life satisfaction, which we call distressed or troubled. And the practical implication is, of course, that especially in the case of people who are not doing well in their lives, it's reasonable. And there's some research we cite in this paper that you see there. It's plausible it can have an impact on also how effectively they're able to learn and benefit from training. So it's worthwhile to sort of like note and know also perhaps also what are the determinants of these life satisfactions and stresses. And we can't really determine causality, but what we saw seemed quite plausible. And we saw, if we just note the sort of significant predictors, we saw that people who generally experienced themselves as warm and open and caring in personal relationships, or genial as it was termed, generally experienced more satisfaction in their lives, whereas trainees who felt themselves to be more reclusive, even in their personal relationships, felt more stress in their lives. And likewise, being anxiously attached was associated with both lower life satisfaction and greater stress. If you have to be insecurely attached, it's better to be avoidantly attached. So there's also some associations not shown here. We looked at, for instance, the impact of nationality. If you know something about happiness research, nobody will be surprised to hear that Finnish people were the most satisfied with their lives. I'm a Finnish person myself. I'm always interested in these results. Generally, if you ask a Finnish person how they're doing, they say it could be worse, and that's a 10 out of 10. And I'm personally ecstatic right now, and this is what it looks like in Finland. So you can't always judge a book by its cover, but this is what people say on the questionnaires, it turns out. What seems maybe more intuitively understandable is that we also saw, for instance, economic conditions, both in current life and life historically, to predict unhappiness. So if we want to look at factors in trainees' lives which we can impact, economic support for trainees, for instance, is something that is a determinant of well-being and stress, and something that can be impacted. Also here, just to mention some ongoing research, we've looked at people's varying backgrounds in how they actually find themselves into the therapist profession. And I don't want to go too much into this, but I'll just say it looks there's distinct pathways, so both professionally and personally. So some people go a fairly conventional route with more or less background in the mental health field, whereas for some it's a kind of an extra thing or something more out of the box in relation to what they've done before. And similarly, also personally, there's different stories. There's experiences of really being nurtured, but then also substantial numbers of therapists having experienced either challenging or what could be characterized as really failing family backgrounds. And we can also ask how are these professional and personal pathways linked, and linked with the theoretical approaches that people turn to as trainees or when they go to train. So that's some ongoing research. And then just to say, we wanted to investigate also, since we had the chance to look at how this self-report questionnaire that was used to evaluate trainees' current practice experiences, their skills and difficulties and relational agency and feelings, to what degree the sort of the psychometrics of it appeared acceptable and reflecting a sound structure. And This was published, I guess it was last year in Psychotherapy Research, and where we used both the collaborative research network study of therapists, graduated therapists, and then also the sample of trainees that we had collected here in the SPRISTAD longitudinal study to evaluate the structure and its soundness and reliability in both groups of therapists and trainees. And where really we saw that the psychometric properties were quite sound and satisfactory or even good. And just to briefly now go a bit more deeply into the what these domains actually comprised. So the domains that I mentioned earlier experienced skillfulness and difficulties and relational manner and feelings in therapy work. So starting with the area of the therapist role performance or what the therapist does, we can identify essentially positive factors such as experience of basic relational skills, which really refer to very fundamental skills of relating, like feeling empathy, being able to establish a working alliance, communicate caring to another person and so forth. Professional expertise, which reflects more finessed skills such as capacity to detect clients' feelings and one's own feelings and use them in the therapy process, understand kind of what's happening moment to moment, and so on. And on the other hand, we could also identify factors like professional self-doubt, which was also in the CRN's DPCCQ questionnaire, and which has, of course, been made quite famous by Helena Nissen-Lee, my departmental colleague, who showed that greater professional self-doubt was actually related to better outcomes of patients. Although with trainees, it's not clear that there's a similar association, since there's actually sort of opposite association was found. So this may be different for trainees, which doesn't sound at all implausible. Also, other aspects such as negative personal reaction, which is characterized by items like not being able to see anything to like or respect in a patient. Then these difficulties, these must be somehow coped with. And so here there may be more constructive methods like consulting colleagues, supervisors, reading literature, and so on. And there may be more avoidant coping methods, like just hoping the problem will go away eventually, or binging on Netflix or whatever one does. And so then the other area, therapist role identity, who the therapist is or experiences him or her themselves to be. Here the factors that emerge were dimension of affirming and warm, accepting relational presence, a confronting, directive, authoritative relational manner, and then what was termed a skillful or efficacious relational presence. And then accompanying those, we had factors describing an experience of flow and creativity in sessions, or feeling anxious and beleaguered, or bored and inattentive. And so these core domains and items were for measuring skills and difficulties and relational agency and feelings were termed the therapist work involvement scales, or TWIS, which you see there on the top of the slide. And these core domains have been adopted for many trainee and therapist outcome studies where the adoption of the full questionnaires has been too much. And so if you're interested in those, you can also approach Ulrike and Jan. So, maybe now just to very briefly say, because maybe you've noted these terms healing and stressful involvement there, and it's relevant at this point, I'll just, without spending too much time on this, I'll note that this is the sort of like the factor structure that emerges then from these what are called the first order factors of the skills and difficulties and feelings and relational manner. And this is from my PhD actually, which used the DPCCQ, but it's been adopted for adapted for this purpose kind of. But anyway, the point is that these experiences of various difficulties in practice, the coping methods for dealing with those difficulties, and the feelings that are involved then in the therapy session, and the way of being there, they form these super factors or second order factors of healing and stressful involvement that kind of globally characterize the experience of therapists and trainees of therapy work, where the healing involvement is characterized by a feeling of skillfulness and efficacy in therapy work, an affirmative manner with patients, and a constructive way of coping with difficulties, where the stressful involvement is then characterized by anxiety and boredom, coping by avoiding issues, and then frequent experience of difficulties in practice. And there's some studies on how these actually predict outcome, some of which we've reviewed with Helena in a few years ago, if you're interested in that, but there are some studies on this. So continuing on that note, how then these experiences of therapeutic effectiveness and stresses, what are their patterns and correlates in trainees? Again, here, as with sort of life satisfaction and stresses, it's not actually that one rules the other one out. So you can both feel you're doing good work, but at the same time also that you're stressed out and grappling with difficulties, and probably more so when you're just starting out. And again, here we had about half of the trainees who were fortunate in that they were feeling they're generally effective, feeling more than moderate healing involvement, and not too much stressful involvement. But then about 1 in 10 we might be worried about who experience a lot of stress and only moderate or less healing involvement. And so, as noted, we haven't really yet validated these patterns to trainee experiences to patient outcomes, but at least subjectively thinking you'd take a greater sense of healing involvement to be a good thing, and lesser stress to be desirable too. So what then sort of is correlated with these experiences? Well, first of all, we saw that younger people are more stressed out, perhaps expectable. Parents are also expectable too, perhaps, although parents also felt more healing involvement. And so having kids can do both of those things for you, apparently. Marriage doesn't make that much of a difference. Maybe it's the quality of the marriage, but marriage by itself, no. Again, if you're open and warm or practical in your relationships, you're also more likely to feel more effective as a therapist. If you're insecurely attached, it's the other way around. And also you're more likely to be stressed out, which makes sense. So, and if you're satisfied with your life and not stressed, you're going to feel more effective as a therapist. Whereas if you're more stressed out in your personal life, you'll also feel more stressed out professionally. So what it really shows is that the professional and personal lives of therapists are closely intertwined. And personal therapy actually didn't make that much of a difference, at least not that we could see with a simple correlation. But so anyway, I do think these patterns do seem to paint a profile of therapists who are more secure and content in their professional and personal lives, and those that are, shall we say, more neurotic, or whatever word you want to use. But we also definitely still want to go more deeply into what these patterns actually mean for training or learning outcomes and therapy outcomes too. But it points to the diversity of trainee experience. And so then now finally continuing on that note, do we actually see any change in trainees in these various experiences of skillfulness and difficulties and relational being and feelings in a longitudinal design? And if we actually compare their responses over successive measurement points. And the answer is yes. And this is in review, so I'm not going to go into this in much detail, but we do see experience of skillfulness go up on average, statistically significantly. We do see experience of difficulties such as self-doubt and negative personal reactions to go down statistically significantly, relational manner to become more affirming and accepting, and anxiety to decrease. But what we can also say is that these average trends mask significant variability. So we have these trainees who start out training feeling a lot of healing involvement and not a lot of stressful involvement, and they just continue on that track doing well. But we also see people who are what we call in challenging practice at first, so they're feeling a lot of considerable healing involvement, but also stressful involvement. But then they start going down in both, so they kind of seem to start disengaging from therapy, and which could be worrying. We also see people then who aren't doing well at the start, but then who actually do improve significantly. So, but the main implication being really how do we spot these sort of deleterious processes. So, no surprise, it happens every time that time goes faster than you think, but fortunately I am at the conclusions. So, so maybe I'll try to wrap it up quickly. So main points: training programs value emotional maturity and intellectual capacity in selecting trainees. Key implication for researchers, obviously, to identify the characteristics that make a difference and how well we can evaluate them. Trainees' well-being are clearly impacted by both their life history, but also their current situation. And so if we presume that may impact also their learning, then we should understand these risk factors better. But we can say about half of the trainees at least seem to be doing quite well, both in their professional and personal lives, and also that the professional and personal lives, they are really intertwined. And this is only self-report data, but still, I think, with that caveat, I think it's a connection that's worth noting. The psychometrics appear satisfactory or even good, and we do see skills to increase and difficulties to decrease, and all good things, but there's considerable variation, which is worth noting. So really identifying the groups at risk and their determinants could enable targeted training or targeted interventions to prevent deleterious outcomes, and also identifying the features of training programs that trainees feel most predict positive change is obviously has implications for training programs. And as a sort of very, very long-term vision, if we're able to provide some kind of benchmarks that would actually enable feedback to trainees and or training programs about how trainees are doing based on these scales. That would obviously be valuable. So the strengths are, clear that it's not just based on a single site. It's from a number of places. We had a really kind of comprehensive measurement of various aspects, rich data, and also several measurement points to track the change. And the limitations, of course, it is based only on self-report, and but also having said that, in the end, therapists and therapist trainees are really the ones who ultimately do the therapy. So their viewpoint, we'd argue, has significance. But we do want to supplement this with outcome data, obviously, from patients. And although we had a large group and we were able to do all sorts of subgroup analysis, also some group analysis, we are beyond the current database. We also have some qualitative studies going on about the open-ended responses here about why people wanted to become therapists, what they feel are their greatest limitations, what are the most helpful or hindering or the missing aspects of the training. Those are all ongoing. And there's also a bunch of studies that have taken these scales or the short form, the twist forms, and are collecting patient outcome data. So we're looking forward to seeing those results and findings. And then also triangulate both the quantitative and qualitative data together with the patient outcome data, of course, with the sort of the ultimate final aim to sort of for all these different kinds of therapists to really help them reach their full potential. So that's it. I'm almost on time. Just wanted to say that if you're interested in participating or becoming a member of the SPR Interest Section, I am the person to email. We have all sorts of activities and new stuff that's happening, and we're building up now. And if you're participating in the SPRISTAD longitudinal study, Ulrike and Jan would be the persons to email. I apologize that this went so much to the last minute, and I want to just give a shout out to all the people in all the papers that you saw here.
Yeah. So, Erkki, is it still possible to join the study? That's what you're saying? Or
Yes, that it is possible, and people are joining it.
still
So
joining?
yeah.
Okay. So first of all, let's have a big hand, and we can take a few minutes for questions, right? Because there were some really interesting questions on the chat.
Sure, absolutely.
And we'll go for like maybe another 20 minutes, and whoever can't stay, can't stay. One question that people wanted to know is, would your slides be available, or would that be just on the webinar or whatever? What I mean,
Sure,
because some of
I
it
can.
is in progress.
Absolutely,
Yeah.
absolutely, yeah. I mean, I'll have to maybe take some of the cartoons and Ben
Yes.
Affleck out, but yes.
Okay, so we'll arrange for that. And then I joined Kim's question because I was just introduced in Israel to the possibility of using AI as a possibility for development and training. And is that something you're looking into?
Yeah, I mean, that's a really, really interesting possibility and idea. And yeah, I mean, I guess everybody is looking into that at the moment. So yeah, and there's different ways. So I'm not sure if you had a more specific idea there, but
I don't know.
yeah,
I'm reading Kim's question, which says,
let
moving
me.
forward, are there any plans to add a module in your study on AI-supported training in any of the instruments? Like, would that be an additional item or a question?
Right. Yeah. So adding a module on AI supported training. Yeah, I mean that would be certainly possible, I guess. Yeah, and that could be discussed in the. So that would be sort of like, if I'm understanding the question right, and Kim, please correct me or fill me in. Are you talking about sort of like modifying the instruments, like adding new stuff to the instruments, or are you talking about using AI in some other way in combination with these instruments?
No, I was actually wondering, given that you are assessing among so many different programs,
Yeah,
could be a really good opportunity given the development of AI supported training that's going so fast,
yeah,
to kind of get more of an overview of which programs are already using AI.
yeah,
Like I think for
yeah,
now, just adding something to get some insight into sort of how widespread is it, and are people thinking about it? What are people's
yeah,
experiences?
yeah,
If relevant, could be a
yeah,
good opportunity for SPRISTAD
yeah,
potentially to kind of get an overview of that. So I wasn't
yeah.
really talking about really already implementing it, because I think
Right.
that's happening anyhow. But I think specifically for SPRISTAD, it could be an opportunity to kind of assess where training programs are at right now with
Yeah,
AI
Yeah.
yeah.
modules.
That's a great idea.
And I'll add something I've started to hear from my students. I feel like I'm behind, that they're also consulting the chat GPT or anyone else on their clients in addition to going to supervision. So they're also
Mm,
already using it, sometimes formally, sometimes, I don't know, behind the supervisor's back. But they're using it a lot more than I thought, just to kind
yeah,
of
yeah,
get another opinion on what to do with
yeah,
their clients. So
yeah. Yeah,
I
no, but I mean that's a great idea and really important, yeah, area.
Okay, Justin, you wrote that you have a qualitative study under review which examines some of those same aims. Do you want to say something about that, or?
I mean, I just saw on the slide towards the end that it was mentioning there were other qualitative studies, and I just felt excited. I wanted to share, but I didn't have anything prepared or anything I was going to say about it.
Oh, okay. So fine, great. So let's hope it's accepted and then we can read it.
Yeah, absolutely. I'm
Um,
looking forward.
Piero, any effects of therapists' well-being on therapeutic alliance? I
Yeah,
think, yeah, I think
yeah.
you said,
Go ahead, Oria.
no, I just read the question. That's it.
Yeah,
It's
yeah,
your
yeah,
response.
yeah, yeah. To be honest, I don't actually remember. If anybody else remembers, feel free to shout out. I think, I'm sure we did review the literature when we did the paper on therapist trainees life satisfaction. But it my recollection is that we didn't find really anything that like directly looked at that. But I could be wrong.
Mhm.
David, uh,
Yeah.
well, I'll say one thing if you'll allow before David. We did find in the Helsinki study, which I'm leading, and which used the DPCCQ, which is assessing a lot of these same domains. We did see that sort of how therapists felt they are in their private lives with in close personal relationships. That really predicted their
Mm.
assessments of the working alliance. So that therapists who felt they're more reclusive and so on, they evaluated their working alliances quite negatively, but it didn't have any effect on the patient's experience of the working alliance. So yeah, I mean you have two people there in the therapy room. But sorry, David, you were going to say you're muted now.
David, can you unmute?
I unmute.
Yeah.
I was going to say basically the same thing, that we are so far, at least within the SPRISTAD study so far, limited to what the therapist can experience. And also wanted on a separate issue, which is to say the self-report issue that as a limitation, that there's a continuum in self-report between self-observation of specific behaviors or traits and opinion, like how good are you as a therapist? That and there's always some degree of opinion, obviously, and some degree of self-observation, but that you can distinguish variables, self-report variables that are primarily self-observation, which we have in many of the TWIS aspects, and those which are more self-opinion, where we ask, how much, do you feel you're growing as a therapist? That's obviously an opinion. So I just wanted to make that distinction.
Right.
Yeah. Another really important question, I don't know if you thought about it, because I think this is such great research. You can add more and more and more, and you have to set limits. But there's a question on, is there a comparison between trainees who responded to the study and a group that did not receive the self-questionnaire intervention? And does this support the hypothesis that participating in the study facilitates self-reflection and reflective practice in their training and professional growth?
That's great. That's great.
Yeah.
We could do that. It would
Yeah.
be really interesting to study recidivism.
Yeah.
Who drops out? Great idea. Thank you, whoever came up with that.
And
My response to AI is OY. Oi.
no, I agree. But I'm realizing, that's why I said I'm behind. My students are telling me that this is what everyone is doing. So if they're doing it, we better find out about it. That's all.
You're right. And Kim's suggestion is very good. I mean, we could clearly add one or two questions, both to the training program, description form for the trainers, and for the trainees. So, I mean, it wouldn't take much, and we could add, and it is, I mean, I'm a fossil, so it doesn't mean but, I mean, literally, but you're right, it's not only the future, it's the present.
Yeah, which took me by surprise. This is what I'm trying to say. So even if I'm almost a fossil, I was wondering how come I didn't realize this was going on. So, another question, I think this is the last one I see. Is there a difference in outcome between therapists who've completed specialized postgraduate psychotherapy training and those whose highest qualification is a master's degree without additional? So if I'm getting this right, do we see further development or satisfaction or whatever from trainees who participate in, more training programs past their degree? Do you see that?
Having
Go ahead.
written several reviews for the Bergen-Garfield handbook in the past, my guess would be no, that it's more related to personal characteristics. But I could say also that Helgi Rannestad and Armin Hartmann and I are currently studying trainees who have had no prior treatment experience, which we call neophytes, from versus trainees who have had 5 or more years of treatment experience before coming back for entering a training program again. So that could possibly shed some light on a analogous question of what differences there are between training absolute beginners versus
Mhm.
adding to the training of experienced therapists. And I can't tell you any results,
Yeah.
but
Yeah.
in some respects, they are different.
Yes. Yeah.
Mhm. Marvin Goldfried's question, any findings regarding therapy orientation, satisfaction, feelings of competence? Did you see any difference? Like,
Minor, either none or minor.
really?
Yeah.
Okay.
Maybe
Katerina?
for Marvin, I would say that the CB therapists tend to feel better
I
about
think
their
so.
work.
I mean, my hunch is at least at the beginning stages, because I don't know, it's clearer than
Yeah.
doing psychoanalytic psychotherapy when you're just beginning and you probably don't have a clue. And
More structured.
yeah, more structured.
But what I always think of as a fun finding is that therapists who come from large families are more inclined to find systems orientation, family systems orientation to be important for them.
Wow.
Hmm.
Katerina is writing, if you want to say something about it, Katerina, that you're working on a qualitative research on the experience of being a CB therapist, where your participants describe in detail how their well-being, where is it? Sorry, I skipped, sorry. Where you said the qualitative research, the experience of being a CB therapist, where my participants describe in detail how their well-being is linked with their perceived capacity of being close to their clients and building therapeutic relationships. I'm preparing the paper. So do you want to say something about it? It sounds interesting, Katerina.
Hello, thank you. Not really. It just came to my mind when you were discussing if there's a link between well-being and the outcome or the therapeutic relationship. And this, what I found, this gap in the literature. So this is why I designed this study, and that's why I shared with you. So.
Wow. Okay.
Yeah. Yeah, I mean, it sounds very much like, around some of the same sorts of associations we see between the professional and the personal.
Mm-hmm.
Can I follow up on my question, Marvin Goldfried, about theoretical orientation?
Yeah.
Since practicing clinicians go beyond their theoretical orientations once they start once they're confronted with limits of how the orientation maps onto the particular case, I'm wondering if the beginning therapists don't experience this at all and consequently stay within an orientation. And then a related question is, do you have data on whether or not, what percentage of the training programs are theoretically oriented in nature from the outset,
right,
versus being more trans-theoretical from the beginning, since there seems to be a trend in that direction?
Mm-hmm.
Yeah.
So are there any data that you have on that?
Yes.
Yeah.
Yes. There are data on that we haven't looked at yet, but the study is so, in a sense, so data rich that it takes a while to explore all the research questions that are implicit in it.
Mm-hmm.
But that's a good one. I mean, how would you formulate that exactly?
A simple question would be, are trainees who are trained trans-theoretically more likely to be satisfied with their clinical work or not? It seems to be a very important question that might be toward the top of one's hierarchy of questions to look at.
Yep. One of the Helgi, do you want to respond?
Yeah, two things there. I think that, in the CRN, we have pretty strong evidence that therapists who are influenced by various theoretical orientations come out better in many domains. So I think that is an answer to Marvin's one question. On the question of whether therapists change in orientation, and in particular, if students do, we have several reports from the Minnesota study of students who are disenchanted, disappointed with their theoretical orientation, and they change. And there are reports of not getting the results they wanted with a particular orientation, not being able to establish a working alliance to the extent that they had hoped for, that forces a change in theoretical orientation. We don't know the frequency or the base rates for this, and the CRN or the SPRISTAD study, we could find that out. Yeah, but it certainly is a dynamic.
Mm-hmm.
One of the scales that we use for assessing the theoretical orientation of the program is specifically integrative, and so. But I would need to. We have the trainee perception of the program, the orientation of the program that they are in, and I believe we must have the training director's statement of that. But it's been a while since I looked at that data, and so when we finish our nice discussion today, I'm going to look at that, and if we do, I can write to you, Marvin. I mean, you know, we can explore that particular question.
Yeah, yeah. I may also, get back to a previous issue. I guess, Warya, you asked the question if more experienced or therapists who return to training obtain better results. That we do not have data to answer that, but we have data to address the potential dynamics that concerns that. And that is the nature of our SPRISTAD data. We thought originally the great diversity in clinical practice that characterized the trainees was a problem methodologically, but it turns out to be a great asset. As we have data, we have 10% of graduates have more than between 5 and 10 years of clinical practice, while another 10% has between 10 and 20 years of clinical practice. So we're able to, and we're doing that right now, to see if these novices, how they compare with the more advanced trainees. We made the cutoff point at 5 years of clinical practice. And we're already finding numerous interesting findings. One being that the trainees are extremely vulnerable to the effect of stressful involvement.
You mean the neophyte?
The neophytes, the beginning trainees, the neophytes, or they are the degree, if they experience low healing involvement and high stressful involvement, the chances to currently experience loss, losing their energy, losing their enthusiasm, losing their vitality is considerable. Well, it seems that the more experienced trainees, those with above 5 years of clinical experience, have some kind of a buffer against the detrimental effects of this stressful involvement. Yeah. These are just some of the preliminary findings that we're able to ask now with a focus on currently experienced development. That's our focus in the paper we're writing now. Yeah,
so it's really interesting what helps them develop the buffer. Is it just that you gain more experience? Is it something that goes on continuously in supervision that who remains and who drops out of the profession. You know, what does it take to move on and to be able to deal with? Because when I was looking at the items, so yeah, it's, you know, there is a lot of supervision focuses on skills and relationship skills and therapy skills and intervention. And those items on how do you deal with negative feelings, you know, how do trainees learn that? All those difficult things that, you know, which really don't depend on orientation, but how do you deal with challenges?
Yeah.
Okay.
But that finding seems to sound an awful lot like the conditions for burnout, where there's high responsibility and low effectiveness.
Yeah.
Clearly, if it goes on in that direction, you would come to a burnout situation. But if you get like support support in the workplace, supportive supervision, support from your peers, that helps very much to counteract the effect of that stress. It's really, support turns out to be a critical factor. Getting support from somewhere.
I would think good supervision is also important because it would increase effectiveness.
Yeah, absolutely.
And are you collecting any data or maybe even partial data from supervisors, or is it mainly the trainees' experience?
We have an instrument for supervisors that is parallel to the trainee. And we have, unfortunately, only 24 hours a day and 7 days a week. And so if there's some colleague who is interested in supervision, we would give them this instrument and say, let's do it, join, you know, here it is, look at it, maybe you need to want to change it, but yeah, it would be great.
I may add here to that in the instrument that we're using, it's called a brief supervisory alliance scale that I know that one. And it's, you can, if those interested, it is in the appendix of Bernard and Goodyear's supervision book, and also in the latest one that is about to be published now. I talked to Rod Goodyear just the other day. So it appears there, and 8 of those 12 items are included in the SPRISTAD study.
Are there data to show that moderates the stress?
No, I'm sorry that the literature on the direct clinical impact of variations in supervision and quality of supervision, typically measured by one of the supervisory alliance scales, is meager. It's meager, and it's hard to establish a causal relationship between quality of alliance and clinical impact. And I think the reason is that there is most of the variance in psychotherapy outcome is attributed to the client, and the rest of the variance, to sort out the specific impact of supervision in the infinite myriad of complexity that will impact the quality of the therapeutic alliance, is impossible to do within the designs we have, especially focusing on experimental designs. I think it is an impossible task to do it that way. You have to do other methods to assess it, like subjective experiences of participants. You cannot do it with experimental designs, I claim. If you were, you may be able to explain a fraction of a percentage of variance. That's all. Not because it isn't impactful, but you cannot measure it that way. Amen.
But I would suspect that the findings would vary as a function of the severity of the clinical cases. That if
Yes.
these are very severe clinical cases, then you're not going to get findings. But if it's more variable or if they're easier cases, then the supervisory impact is, I would guess, is likely to be more positive.
That would be one of the variations that will explain no findings or minimal findings. One of them, yes.
Yeah.
I believe.
Okay, I think we have to end here. First of all, thank you, Erkki. This was terrific. Thank you, everyone else. It was great to have everyone, David and Helgi and Marvin Goldfried, and Kim had to leave, but this made me think that we really don't hear enough about supervision at SPR. So it would be great if we could hear about it a little more. And okay, so the webinar will go on the EU chapter website in a while, right, Galit? And thank you, everyone, for joining us, and have a good day. Bye-bye.
Have a good day.
Bye.
Bye-bye.
Thank you very much. Bye-bye.
Thank you.
Bye.
Thank you, Erkki.
Thanks.